I'd like to welcome you to this last session for the afternoon, Simplifying Medicines and Other Management Strategies for COPD. We're very fortunate to have Ainsley Ringma talking to us today. Ainsley is a registered nurse. She's been a registered nurse for just a little while. We won't say quite how long. It might give her age away. She has qualifications in nursing, health promotion, health management and asthma education. And for the past 15 years, she's worked in respiratory medicine. She sees patients on a daily basis with COPD, asthma and other respiratory conditions. Ainsley works in the community and in hospital settings for Metro South Health Service District, as well as a consultant for the Lung Foundation of Australia. And I'd like to say, before I forget, because I always forget to do this bit, thank you, Ainsley, for coming along today and talking to us. And I'm sure we're going to all learn quite a bit from this session. Thank you.
Hi, everybody, and welcome to Queensland. Are you mainly Queenslanders or from all interstate?
Victoria.
Well, the good thing is that COPD is the same wherever you go. So I think that the things that we're going to suggest for you today, you can take them anywhere in Australia and anywhere in the world, I would imagine. So that's just recognising the people who put together this program here, and there's the learning objectives. Most of you look like you've probably been nursing for a wee while as well, so you probably already know a little bit about COPD, but maybe we'll just cement some of that information for you. There are a lot of new medications out there, and I think that's probably what most people are interested in. Outline the recommendations for the introduction of medicines as the COPD increases in severity. COPD is not a static illness. They don't just breeze up and become severe. We usually see them, and especially practice nurses, see them through all stages of the COPD. Also going to review inhaler device techniques and hopefully clarify the role of the practice nurse in COPD management. In fact, you may be able to help us clarify that role probably more than me clarify it for you. So COPD, umbrella term for emphysema and chronic bronchitis and chronic asthma. You may have heard of the overlap now. They're now calling it COPD asthma overlap. I think that most of us were aware for quite a while that people with COPD often had asthma. Asthma does not cause COPD, but asthma can develop into a COPD in the terminology that it is a chronic obstructive pulmonary disease. I try to differentiate when I'm talking to the patients because it isn't caused by smoking. So they do get a little bit upset if you say you've got COPD from asthma and they go, but I never smoked. So I always try to explain why I've popped it into that category. And there's that overlap. This isn't exactly how it's going to be, but it just gives you an idea. And I think the other thing to probably remember is that it's not just those three. You might see people with bronchiectasis or lung cancer, any other respiratory illness, interstitial lung disease, as well as these other illnesses. But they're the main ones that we see. And of course, the main cause is smoking. Any ideas of any other causes for COPD? Yep. Yeah, asbestos doesn't cause it. Most of them don't cause it as such, but if you have that contact, you are more likely to develop it. And we know that if people who have had contact with asbestos and smoke have much more likelihood of getting COPD. And the ventilation defect in COPD, you have normal lung function. It's mainly the air trapping. We can't get that air out. So they use like the idea of a balloon, and we know that when the patients talk to you, they're telling you, I just can't seem to get the air out. So if they can't get it out, they're not going to get it back in again. Do you do spirometry? So when you're doing spirometry, you see with the FVC that it just keeps going forever with people with emphysema. And it's like, when are they going to stop? It's because they just can't get that air out. So if you're ever talking to patients with COPD and they say, I can't do my lung function test, they probably can do it better than we can in regards to that long FVC. Main symptoms, chronic cough. It may be productive or non-productive, so you can't say that all people with COPD are going to have a productive cough, because they may not. Regular sputum production and breathlessness. Those elements are really important to keep coming back to, because when we're talking about severity, we'll keep coming back to those things. And also, if we're talking about exacerbations with patients, we want to know what their normal is, how much they do produce, how much coughing they're doing, do they cough every day. So learning what their normal is, so then you can work from that with how that they are with an exacerbation. The main symptoms, here we go. Is it productive or non-productive? With a lot of the emphysemic, if they're just pure emphysema, they may not have a cough at all, so they won't produce. But most people don't just have emphysema, they'll have the chronic bronchitis, and it's the chronic bronchitis that will tend to have the cough and the sputum production. The other non-specific symptoms, frequent respiratory tract infections, more so if they still smoke, because you know that if they're smokers, they're more likely to get respiratory tract infections, and you'll see the patients come in quite regularly with that. Wheeze and chest tightness. I don't hear a lot of my patients say that they get wheeze. They don't identify with the wheeze unless they've got the asthma, but sometimes they'll say, yep, can definitely hear it. Chest tightness, I don't know why it confuses them, because I say, do you get a chest, are you tight? What do you mean? So I don't know, we probably all have our own expressions. I say to them, is there an elephant standing on your chest? Do you have elastic band around the chest? And try to find out what I think will suit them. 1 in 7 people in Australia over 40 have COPD. That's actually quite staggering when you think about it. And I would imagine in the practices you're going to see more people than I do, which is ironic because I'm a respiratory nurse, but you're going to see 1 in 7 have it, whereas I see them when they come in when they're having an exacerbation. So I usually see them moderate to severe, whereas you're likely to see them in the early stages when they're first diagnosed. And that's also the other thing, half the people have not received a diagnosis. So again, they turn up in hospital, they've got a pneumonia. Whilst they're in hospital, they do a spirometry and x-rays, and the doctors say, oh, guess what, this person's got COPD. Can you just go and tell them about that? Which is pretty scary for these people who've come in with a pneumonia and walk out with a chronic illness. So if we could diagnose it earlier, then we actually can help manage it better and maybe avoid that sudden... I've had people who've had an FEV1 of 23%, and that was their first presentation. And they didn't pick up. They were breathless, but hey, I'm getting old. So they didn't pick up with their breathlessness. So it is important to be aware that we should be catching them in the early stages, and the GP practices are the place that we should be catching them. It's the second leading cause of avoidable admissions, and at the moment, I'm sure it's the same for you all over Australia, we are getting pressure not to have people represent to hospitals. And when you think that they say it's avoidable admissions, I'd sort of argue that if somebody's that sick that maybe they need to be admitted, but I think what they're trying to say is if we could identify that their infection early and treat it early, that we can keep them out of hospital. So I think we need to work on that one.
Excuse me, Ainsley, can you tell me what the first preventable admission is?
I think it's cardiac, but I'm not 100% sure.
It's actually diabetes.
Is it diabetes? It's a tricky one with the diabetes too, because they'll often come in with something else and then we'll find their diabetes obviously plays up. It's cardiac third then. Yeah. So, early diagnosis. We can slow the disease progression, and of course the first thing there is that if we know that they're still smokers, we can really go all out to encourage them to stop smoking. Improve symptoms, keep people out of hospital, and that in itself reduces the burden on patients, the carers and the community. And it does affect the family an awful lot, because there's often I've seen my grandmother or my mother die with emphysema. I don't want my dad to be on oxygen, and they've already got this preconceived idea of how it's all going to develop. So we do have the COPDX guidelines. Have they ever accessed that online or had it sent out? Yeah, it's very good. I really like it, and I use it a lot with my education for the doctors at the hospital, because often we've got young residents who have absolutely no idea, even though we know COPD is so prevalent. So I'll give them a copy, or I'll say to them, go to this website. And it is interesting that people don't use it as much as I think they should. This is, to me, one of the most important things, and I think we've got that in the package, haven't we, Judy? This is your summary of the stepwise management of COPD. This, to me, is the most important thing from today. Your medications fit in with it, but you need this to be able to know what you're doing with it. So it's a stepwise management of stable COPD, and it does say stable, so we're not talking about somebody who's in an exacerbation. And we're going to go through that in a fair bit of detail as well. And on the back of that, the other page is the new medication. And this is a bit of a godsend, really, because there's so many new medications out there at the moment, and the patients come in, and you guys are probably not too bad in the practices because that's where they're going to start it. But when they come in to see me for education and I say, what puffers are you on? I get some very strange stories about what they're on. So this is really good now. I can put it in front of them and I can say, can you just point out to me what puffer you're actually taking? Gone are the days when you would have them say, I'm on the purple puffer or the white one with the red bottom. It's now so many different ones, so it's good to be able to have it there for them to see. And once again, we're going to go through this in a fair bit more detail. So with the stepwise management, we talk about pharmacotherapy and then non-pharmacotherapy. Most of what we're going to talk today about is the pharmacotherapy, but for me as a nurse in a hospital, this is probably the more important thing and the one that actually I really love to talk about. So the non-pharmacotherapy for COPD, and we break it into mild, moderate and severe. And there are various things that we can do to assist patients in all of those areas, and we will break that one down. So the first thing, I'll go back, sorry. The first thing for anybody, it doesn't matter where they are, is smoking cessation. And we have to introduce this in a non-judgmental way. Gone are the days where patients walk in and the doctor says, well, if you don't give up smoking, you're going to die, so give it up. It's like, how well did that happen? Didn't work, did it? There were some patients who went, oh, okay, fine, I'll give it up. And the rest of them went, well, no way, I really want to keep smoking, give me a reason. And we didn't used to explain to them very well. So now we have to be a little bit more understanding. It's the most addictive drug that we've got out there, and it's legal. So I've heard all of the arguments. I've heard the discussions on that the government should have stopped it and banned it, and it's a conspiracy, and it's not really the smokes that are doing the damage, it's everything else. But we know it is, and so we have to help people as much as we can. And so the first thing that every health professional should be saying, are you a smoker? And when they say no, the next question you say is, have you ever smoked? Because I can tell you when I say that to them in ED, the next question is, have you ever smoked? When did you smoke? When did you give up? Oh, yesterday when I couldn't breathe. So be aware that they're going to tell you what they think you want to hear. It's not necessarily what we really wanted to know. So I always do say, have you ever smoked? And when was your last cigarette? Same as when did you start your preventer? Because you know that they haven't been taking their preventer either. So we're going to offer smoking cessation. This is all risk reduction. Recommend annual flu shots and the pneumonia vaccine. Is there any other vaccines that maybe you could consider for this age group? Yeah, actually that was in... We've said pneumonia one and the flu vaccine. What about pertussis? Not real good for a COPD patient to get pertussis. And they're obviously often grandparents, and having now become a grandparent myself, I've had more colds than I've ever had in 15 years of respiratory nursing off this one little devil. They spread diseases, they're little terrors. They share. 15 years of having people cough on me, doing spirometry, never needed to wear a mask, 18 months, and this child's given me 3 already, so 3 colds. Optimised function. Please suggest that they go to pulmonary rehab. And that's all across Australia. We've got pulmonary rehab programs. You can find out where your nearest one is by ringing Lung Foundation. Most of the major hospitals have pulmonary rehab programs. Make sure they have a COPD action plan. And if they are at the point where they need to have oxygen, refer them on to a specialist. Different states have different requirements, so I won't sort of go into that. If you're all Queensland, I could tell you about Queensland, but I can't tell you about other states. So we're going to include all those things: smoking cessation, referral to pulmonary rehab, immunisation, the action plan, home oxygen, and other interventions that you'll see throughout the stepwise management. Is there anything in there that you feel that you guys do well or don't do well?
Can I just ask a question?
Yeah.
In regards to the pulmonary rehab, I'm talking about Redlands, do you have, as far as referral to there, does it have to be a GP, like a doctor that does referral through the central referral hub? Or anyone?
So I've got to remember to repeat the question. The question is whether we need referrals, and for most services now for pulmonary rehab, they're going to require a doctor's referral. We never used to, but we do now. And the main reason is that we were getting self-referrals coming in and we knew nothing about that patient. So we were like detectives trying to find out what was happening, because none of these people just have COPD. You know, they're going to have heart failure, they're going to have diabetes, they're going to have everything else. And then we're going to start exercising them. So to be safe now, we need to know more about the patient. So yes, we do require a referral, and I think most of them do. And I think at Lung Foundation, on our list, Judy, we actually have whether they need referrals or not. So for different places, if you ring Lung Foundation, they can tell you where is the nearest pulmonary rehab and what is required from you, whether it is a doctor's referral. I prefer anyway to have a doctor's referral, because that way the GP knows what's happening too, and we always send a letter back if that's the case, if we get the referral.
If the nurse does it and she checks the doctor first and puts that in the letter, would that be acceptable? Would the GP approve?
If the GP signed, I'm not going to know whether it was the nurse who did it or the GP anyway. So we presume if a doctor signed it off, that the doctor's actually approving it. I have sent people back. I've sent people back to their doctors and said, I had somebody the other day referred in for pulmonary rehab in his late 80s, bedbound, and could I please see him for pulmonary rehab? I'm like, I don't understand why you would even think we could do that. So, you know, we're very strict with what we do. I'm not sure about others, but we actually have an hour-long assessment just with the nurses, and then they see the physios. Most people I accept, but there are people that I have actually sent back and said, yeah, no, you know, what were you thinking? And some of those have been from my own specialists that I work with, and I'm like, not so good. Smoking cessation, we'll go back to that, what works, and there's a little bit of information there for you. I think the thing to really be aware of is that all of us should ask. It doesn't matter if they've been asked before. We all should be saying, have you ever smoked? Can I help you? Can I make some suggestions? There is supporting evidence that if we can get them onto NRT, nicotine replacement therapy, or some of the oral medications, that it will work better than cold turkey. Although I did read something the other day that suggested the exact opposite, but I didn't see any research supporting it. So at this point in time, we are saying, you know, please do the intervention with them, a little bit of cognitive behaviour change, but offer them some sort of support. And I ring people and just say, how you going? How you going? Are you taking your Champix? Are you putting your patches on? And sometimes we need more than one patch, sometimes we need 2 patches. So we do have to look at that in depth as well. Pulmonary rehab is usually 6 to 8 weeks. exercise and education. For most of those programs, it's twice a week. For the lady who's in my area, if we're in Wynnum, we do it once a week. So we do 2 weeks at Redlands and once a week at Wynnum. But we do 2 programs down there. It improves exercise capacity. And it does. I don't know if any of you have seen anybody who's done pulmonary rehab and have the patients come away and said to you, wow, I can do things now. My favourite story is one of my first patients who's now passed away, but she was so severe that she hardly got out of the house. She started pulmonary rehab. She was doing 5 steps up and down and a minute walk. And we got her to 10 to 15 steps. And she said one day she came back and she said, I went out with my family and we went to the local Surf Lifesavers Club and there were 15 steps going up. And she said, before I did the program, I would have just stood there and said, take me home. I can't do this. But because she'd been doing these steps and her breathing, she actually was able to go up and have dinner with her family. And isn't that quality of life? Isn't that what it's all about? To me, that's important. I think that's really important. The other thing is the sense of control over the condition, because COPD patients get really anxious, really anxious. And if we can teach them how to breathe properly and how to control their walking with their breath, then they can do things, then they can feel that they have control. With our support group, which is now defunct, but our support group, we used to go out for dinner, for lunch, and they would all sit together. Probably would be quite scary if you didn't know. So we'd have a table of COPD patients, a couple with oxygen, and all coughing their hearts out as they do. But they said afterwards, I wouldn't have done that by myself. I would have been too embarrassed to go out knowing that I was going to be coughing all the way through it, but we had, 20 coughing away. I was the only one not coughing. COPD action plan. And this is the latest, hot off the presses. Judy's just updated this, so this is great. Does anybody use a COPD action plan? Come on, be truthful. Yes. 2. Excellent. We're starting to use them a little bit more often in the hospital as well. The important thing with the COPD action plan is that it's discussed with the patient. It's no point giving them a blank piece of paper. And I've had patients who said, how do I fill it out, Ainsley? And it's like, well, you shouldn't be. You should be doing this in conjunction with your doctor. It is really important that we consider what are we doing with this action plan. It's fine to say we want you to have your maintenance therapy and to have a short-acting bronchodilator when you're not feeling well. But what happens when you get worse? You need to have some steroids, some oral steroids, and maybe antibiotics. And I think that's where we sort of fall down. A lot of doctors don't like to give their patients a script saying, start this when, because they think, well, Joan over there, she'll actually start it as soon as she has a cough, she'll be on the steroids. So I'm not going to give her any steroids. That's why it's so important to go through it with the patient and explain. And part of that was earlier on I said about knowing what's normal. With a COPD action plan, the patient needs to know what is normal for them to know when they're no longer normal.
Can I just ask a question? I work both in nursing and paramedicine sort of field.
Yeah.
So is this action plan something that could be presented to an ambulance if they would arrive and
We're trying to, So we are trying to encourage action plans for the patients to say to the paramedics, hey, look, I've got this action plan, especially because it says CO2 retainer.
I was going to say, I just noticed at the bottom it says, because that's always the question.
Yes.
The amount of COPD patients who don't understand what that means, and so you have to sort of treat everyone as if they are, just in case.
Yes. And are you from Queensland?
Yeah.
Our guys used to just put on high flow anyway.
Yeah, we don't anymore. If they're on 2 litres normally, we'll go 2, maybe 4.
Yeah.
But
And that's a fairly new thing. So like when I first started respiratory,
we would changed 2 years ago.
Yeah, we had patients coming in narked. Like they had high flow, came in, and the next thing we had to BiPAP them because they'd been having just too much oxygen. So yes, that's really, to me, one of the most important things. If we do a blood gas in hospital, which we should, if they're in hospital, they should have an arterial blood gas done. Sometimes they're not arterial, sometimes they're venous, so we do get mistakes. But if you have an arterial blood gas, then it should be discussed with the patient. We've done your arterial blood gas, your oxygen level was this, you qualified for oxygen or you didn't qualify, but we should also talk about that CO2. And I think as nurses, it's, if you remember in hospital, working there with them in the ward, having this paranoia of having someone with CO2 retention on more than 2 litres. I'm not going to do that, I'm going to be really careful. So we've included that on purpose, that we hope that the doctors can identify it, put it on there, so that the paramedics can see, oh yes, this person is a CO2 retainer.
Even if they're as bad as silent chest or something, you can't get that sort of go out of the
And what we've got extremes. I've got some patients who have got bands on.
I've seen that.
They have their USB attached to them, and they have on their phone, they actually had it on their phone. There's some program that you could do, and they said to me, so when I'm unconscious, Ainsley, they'll know. And I'll go, well, yeah, okay, hopefully they will, but they really don't want people to give them too much oxygen. Maybe I did my job too well by saying, no, you mustn't have any more than 2 litres. But, I think we're starting to get there with that, and hopefully it will start to go out to the ambulance guys to look for it as well. So we are hoping that we can get them to start taking medication appropriately. And that, I think, is actually going to be the hardest thing. It's easy to say to somebody, take your puffers, but it's really hard to say to them when you start to have a productive cough that's more yellow or green than it has been before, because sometimes green in people is not a change. So, that becomes really hard. They've got green sputum all the time. For the bronchiectasis patients who have Pseudomonas, a lot of them say that they can taste it goes metallic when they've got the infection again. So people do pick up when there are changes. We just have to try to help them to identify what are those changes. And I've learnt so much from patients who've said to me, this is what happens. I'd never heard before that it went metallic. And then I heard quite a few bronchiectasis patients saying, oh yeah, it starts to get metallic. I always tell, oh, it's terrible. Oh, okay. And there's the other one that we've got for our Indigenous clients. And it's also important to have that aspect of when to go to hospital, because we do have the panics and the people who come in panicking, and we're not allowed to have people return within 28 days or I get slapped over the wrist. So we've got to really be careful that they come for the appropriate reason. Of course, if they have an infective exacerbation, they need to be in hospital if they're that sick. And there's where you can find the support from Lung Foundation on their website, or you can ring the 1800 number, the inquiry line there. This is the part you're probably interested in, pharmacotherapy for COPD. This is the part I think that we're also doing quite badly. Hopefully we're going to get some improvement. If people were following the stepwise management approach, then your mild COPD patients would only be on a short-acting bronchodilator and a short-acting muscarinic agent. They wouldn't be on a combination medication because it's not indicated. And if I'll get you to think back of your COPD patients in the mild range, and just I wonder how many are on combination medication at the moment. Any discussion on that? Don't know. We see a lot coming in on combination medication, and the first thing the specialist does is knock them back. So there's no real indication for it at that point. You may add in, though, a longer acting muscarinic agent when you're in the mild to moderate. So really, if you look at that, when would you introduce inhaled corticosteroids? And you've got that one, yep, in front of you as well, the stepwise management's in your pack. Any ideas? Yeah, so in the late moderate, but can you see where it says that they have to have had 50% less of their predicted FEV1 and 2 exacerbations in the last 12 months. So if they haven't had any exacerbations, it would make you wonder why they're on inhaled corticosteroid. There is research that's suggesting that early intervention with inhaled corticosteroid can actually increase their risk of pneumonias. So a lot of doctors are very reluctant to put them on that. So that's why I said seeing people on a combination medication like we had been, you have to wonder why they were popped on that. Consider low dose theophylline. Anybody seen anybody on theophylline lately? Saw one yesterday. So, but he is actually an asthmatic. I don't think I've seen a straight COPD on theophylline. This man fits into the category of COPD with his asthma being chronic. And he's been on theophylline for quite a while and it works a treat for him. Does that all make sense for you, that stepwise management there? I have started to send this out to GPs when people have come to see me for education and I notice that they're not in the right categories with their medication. As a nurse, I can't diagnose. As a nurse, I can't prescribe. As a nurse, I can read a stepwise management plan and go, why is this person on inhaled corticosteroids? So I hopefully tactfully write back saying, I wonder if this person would benefit to not be on this or be on this, and I have enclosed for your information the stepwise management plan. Is that tactful enough, or am I okay with that? Here's the bit where I'm going to play with some things here. So the classes of COP medications, we're still calling our relievers, which is great, and then we just talk about maintenance. So we're not calling them preventers, we're saying relievers and maintenance. And we're going to break these all down even more. But just remember that included in that is your flare-up medicines, which is your antibiotics and the oral steroids. And we are going to look at those in depth. So your beta-2 agonists, and the nice thing about this is that these guys haven't changed. Short-acting beta agonists, the blue ones, the relievers, and do they all look pretty familiar? You've got your salbutamols there and terbutaline. So they're pretty good. There's the long-acting ones. Probably the Ombres is the newest. Have you all seen Ombres yet? Yep. So you can be on a short-acting and you can be on a long-acting, but you would be discussing with them that the short-acting is a reliever that they'll use when they're having breathlessness. And here's some of the side effects. Palpitations, tremor, tachycardia, headache, insomnia, agitation. And I guess we all know about the palpitations and the tachycardia. I've seen a young lass, obviously not COPD, but she was left on her short-acting beta agonist too long and she was ataxic. She was all over the shop, walked in, couldn't walk straight. So, there are side effects from these medications, and we have to respect that for some people they are very worried about using it. I don't like it when people say, I'll get addicted to the Ventolin. That really worries me. Where have they heard that they'll get addicted? So I will discuss that that's not a side effect and that they won't get addicted. And if it's not working for them, it's often because they're at the point where their airways have remodeled and there is no reversibility. So it's not that they're addicted or they've got used to it, it's just a change in their anatomy. So these are your bronchodilators, the muscarinic antagonists. Now I'm only going to say this one once because I can't pronounce it very well, so bear with me. So that's the short-acting muscarinic agents, and I will now just call them SAMAs. Okay, so I have to practice that one. The benefit of having a SAMA is that it also helps with mucus secretion. So for a lot of your COPD patients, the salbutamols don't work very well, but they'll tell you that the SAMA works really, really well. And now we have the long-acting or LAMAs. And have you seen those guys around? Spiriva's been around forever, but now we've got these other guys. And we're going to go through those as well. So we have them all together. Now, you cannot be on a SAMA and a LAMA. So if you've got someone on a short-acting, they should not be on long-acting. And that's the one that we've had a lot of problems with. When Spiriva first came in, we had a lot of people presenting to hospital on Atrovent and Spiriva. It's an anticholinergic, so the side effects from anticholinergics, dry mouth is the most obvious, and they will come in and they can hardly talk, they're so dry. Urinary retention and ocular problems as well, and I've seen all of those problems. I have seen somebody on Atrovent second hourly, which is just scary to see, you know, but it happens. And as nurses, that's where, you know, we're not prescribing, but we can certainly question why are these people on these things. Inhaled corticosteroids. So you've heard where I said before that we shouldn't have somebody who's mild and in the early stages of moderate on an ICS. And in fact, ICS monotherapy is not approved therapy for COPD. The exception, of course, is if the person has asthma, because you're going to treat the asthma. And with asthma, the preventers are the main thing, the maintenance therapy. So there is that overlap that we have to be aware of. But if they're just COPD, there is not approved for monotherapy. And there's your combination therapies as well. And this is where it gets tricky. So I'm not going to call them by all their long names. I'll just say, so you'll have your ICS and LABA combinations. Just remember, if they're on that combination, stop their LABA. They shouldn't be on the single one and the combination. There are the LAMA-LABA ones, and again, if they're on those ones, and to be on that combination, they have to have been on a LAMA and a LAMA individually before they can actually be put onto a combination one. So once they do go across, they shouldn't be on the two different types. So one of the things I do with the patients is I ask them to bring their medication in and I put it down in the pile. And if I see that they've got two in the one class, then I know that we're in trouble. So with mild, we've talked about this before, they really should only be on the short-acting bronchodilators or the SAMA, and possibly turn them onto a LAMA. And moderate, and we've sort of talked about this, so I won't go into this too much again. And there's the severe, you might have them on the inhaled corticosteroid, but once again it would be a combination therapy. Now this little chart is really helpful because we've got so many out there at the moment. You can actually get this, and that's what I was saying, how I put them into piles, and I can see, have I got too many in the one area? And it's with the combinations that it starts to get tricky. And that's in your pack as well. So I've got a case study here. You've got a 63-year-old gentleman diagnosed with COPD 5 years ago. He's had 2 hospitalisations in the last 12 months with a COPD exacerbation. FEV1 of 45% predicted, ex-smoker, and he's currently prescribed medicines, a SABA and a LABA. So our question to you is, what additional information do you need? What non-pharmacotherapy interventions would you consider? What pharmacotherapy would you consider? And what services would you consider for referral? So I'm going to actually pop that out to you. We'll go with the first one. What additional information do you need from Bob?
His breathing status, his cough and how he feels himself.
Yep. So what's his normal, what's he feeling at this point in time? What else?
When did he give up smoking?
Yep. I always ask what their social status is. Are they married? Are they living with someone? Do they have support? Because then you're going to have an idea of what you're going to have to help you there. What non-pharmacotherapy? This is the part that I love. So what would you be thinking to suggest for Bob? Is that's your question for him? Is he coping? Yeah, so that's actually really important. What are his anxiety levels? When I do my assessment, I will always ask them the scale for depression and anxiety, and I will often refer them on to a social worker or a psychologist it's amazing how many people I do have to refer on. What else? What else would we be doing?
Be eligible for the rehab.
Yes. So yes, pulmonary rehab. As far as I'm concerned, everybody should be referred to pulmonary rehab. And there are those, I will put in there, that they turn up and they're working and they're active, and I go, great, you're fine, you just keep doing your own program, that's your own pulmonary rehab. But for most, they will benefit from that group, and they will benefit from learning that they're not alone. A lot of COPD patients do think that they're the only ones out there, even though we know it's so common. What else? Anything else? A GP management plan, yep. When I do my assessments, I actually run through quite a few things. I ask them about incontinence, and usually this comes up when they are doing their spirometry, because when they do their spirometry, they cringe and you think, whoa, okay, why are you cringing? Because I've just pushed down and I'm incontinent. And a lot of them, if you think about it, they're smokers, they're probably women who've had children, so, you know, they're in that risk factor. The other thing is osteoporosis, because they're in a high risk factor for osteoporosis. People who've been smokers or ex-smokers, not active, and may have been on large dose steroids as well. So there's all of these components. So that to me is all non-pharmacotherapy. That's just doing your history, isn't it, and finding out about them. And then it says, what pharmacotherapy would you consider? So we know that he has had 2 hospitalisations in the last 12 months. He's got an FEV of 45%, and he's on SABA and ALABA. What do you think?
ICS lava combo.
Yeah, because he's in the moderate but later moderate, and he's had the 2 hospital admissions. Yeah. So when we are looking at the medications, we need to work out if the patient actually understands what they're taking and why they're taking it. And I don't know about you, but the number of times patients say, look, I just take it because the doctor told me to. And you go, okay, do you know why you're taking it? Do you know what you're taking it for, what it's doing for you? If people know more about it, they're more likely to take it. So when I do the hour talk with them, I include that in part of it. And it's funny how they leave and they go, oh, I'm going to take my medication now because now I know what it was all about. And a lot of the time, I don't think their GPs know that they're not taking it because he doesn't need to know. And they come back to the specialist who's put them on new medication, and I say, oh, so how'd you go? Oh, I didn't take it. It's like, why will they tell us as nurses, but they won't tell the doctors? They have a trust of us, so I think we can use that for their benefit as well as our benefit. How to actually administer it. Now, I know this sounds funny. We say how to administer oral or inhaled. When Spiriva first came out, how many patients took the tablet? Yeah, quite a few. I had a nurse, bless her, she had the Spiriva capsule and she said to me, I don't know, Ainsley, I can't get this working. I'll just grab mine. And we got it out, and honestly, we still don't have them in the hospital. Usually we put them onto Atrovent. We're not a rich hospital, we don't have these fancy devices. So she put the tablet in the top, and she'd been forcing it in, and then she was handing it to the patient to breathe it in. So he possibly could have inhaled it. Thank goodness she worked out for herself that this mustn't be right because she couldn't quite get it in. But if you were handed that device and you'd never seen it before, what would you do? It is interesting, but if that's a health professional, you can understand why patients were taking oral medication. It looks like a tablet. Go for it. It doesn't hurt them, by the way. If they do happen to swallow it, it's okay, as long as they don't keep swallowing it, because it won't actually help them either, so that's a problem. How long will they be on the medicine? Possible side effects and interactions with other medicines. So up to 94% of patients do not use their inhaled medicine devices correctly. I think we know that, don't we? And we also know that we're not very good at showing people how to do it. And the error rate does increase. Now, I can tell you, I see some people annually, and I will show them annually And I've had people at our LungNet conference, the seminars that we have, sitting at the table, and there's a health professional up there telling them how to use their puffers, and they've looked at me and went, "Isn't that good? I didn't know how to do that." And I've gone, "I taught you that, 6 months ago." They forget or they misconstrue what you say. So always take with a grain of salt when they say, "Oh, nobody showed me," or "That's not how I was told." They may have been told differently to what they're now telling you. So just reinforce the correct way that they should be doing it. Poor adherence. If they're not using it, then the disease is going to progress. And that's one of the other things. I have patients say, "It didn't make me feel any better." And I said, "Well, have they checked your lung function? Because maybe it's not making you feel any better, but your lung function was, a little bit better, or there was a reason it's stopping the progression of the illness." Because people will say, "If it doesn't help, why am I taking it?" And I agree, a lot of the time, why would you take it? But it could also be that we're giving it to stop the progression of the illness as well. And if they don't like the side effects, so the most common side effect that people complain about with the inhaled corticosteroids, yeah, and hoarse, really husky voices. I took some for a while. I had a post-viral cough, and I got a really nice husky voice for a while there. So I can appreciate what they're saying with that one. Does this play, Judy, or not? How do I play it? Oh. You might have all seen this.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
I love that. I mean, it doesn't matter how many times you see that, it cracks me up. Because it's true. It really is. And I don't think I've had any... I often have nurses a few times and they'll have heard the story, but I'll say it again. Asthma Foundation, one of the guys there, he's left now, but he was a really lovely fella. And we were talking about this one day, and we all talk about how we sent it around. You can imagine when it first came out, we were all watching this one. And he said, "Well, I had a lady who rang up and said, I don't know what is happening with me. The doctor put me on some medication for my allergy to the cat, and I'm not feeling any better at all." And so Brett said, "Well, can you explain to me what you're doing?" And so over the phone she's saying, I'm having it twice a day. So twice a day I get it out, I give it a good shake, and then I spray the cat. And he's like, Brett was very nice, professional man, and he's, "Oh, well, no, that's not how we normally do it," and went through it. But you can imagine afterwards we're all going, "Oh my God," but really, if somebody hasn't actually shown you what to do, and I'm going to use my husband again as an example, and he hopefully won't hear about it this time. He was put on Accuhela by a doctor who said, "This will help your asthma. Go and take it." So he went to the pharmacist, picked up the Accuhela, came home, looked at it, threw it on the table at me and said, "Well, what the hell am I supposed to do with this then?" So 2 health professionals, the doctor and the pharmacist, did not explain to him how to use it. Is he going to listen to his wife, who's a respiratory nurse of 15 years? Of course not. So, one of the guys at work told him in the end how to use it, and it's really good if you do use it twice a day. Works. But it's that sort of... We do, I think when she said, "What do you think, I'm an idiot?" She isn't really an idiot. But maybe we were for not explaining properly what to do. Or there is the time that I had a young child who was sent to me because he wasn't getting any better. And the doctor had him on an Accuhela, which I would never put a kid on one of these anyway. But he was on an Accuhela. And I said, right, show me how you use it. So he's got it out, primed it. I said, okay, can you show me how you use it? And I'm like, do you not put it in your mouth? No, doctor didn't show me to do that. That's how the doctor showed me. So they did exactly how the doctor showed them. They didn't do it any differently. That's how they were shown. So they weren't wrong in what they were shown. Now, he'd already had his medication upped once, and the specialist had sent him out to me before she actually upped it again. So if they're not getting their medication, or they're not taking their medication, and the doctor thinks they're not getting any better, then possibly they can be going on higher and higher doses and wasting a lot of money as well as anything else. So checking it correctly is really, really important. And we do have so many different ones out there. You've got your metered dose inhalers, with or without a spacer. As far as I'm concerned, never without a spacer. Should be with a spacer all the time. Autoinhalers, breath-activated metered dose inhalers, dry powder devices there. So there's quite a few of them, and we are going to go through them. The potential issues we've got are multiple devices. And despite everything, I still see people coming in with lots of different devices. For simplicity, if we could try to keep people on the same type of device, it would make it so much easier for them. But they come in with like one of everything. It's really quite hard. Musculoskeletal problems. For most of these devices, it is quite hard. And even to activate just your metered dose inhaler, if I've got a little bit of arthritis in my fingers now, and it can be quite hard. You do need quite a bit of force to do that. So if you've got to coordinate that force with breathing at the same time, and you've got a respiratory problem, you've got big issues. You need to use a spacer. There are devices, the HandiHaler. Have you seen the HandiHaler before? Judy, we could maybe pass it around. So if people want to see it, it goes onto the device and it squeezes. So you can actually, if you've got little arthritic fingers like I have, it does help. Of course, it's really hard to get it on in the first place, so you might need somebody to do that. And it just squeezes it. So it's pretty good. There's that one. So just pass it around. And then this one goes on the bottom of your Turbihaler, so it gives them a wider base to be twisting. And that's really quite hard for people if they've got not a lot of dexterity to actually manipulate that. Poor eyesight. And how many times do you see them trying to put it in the wrong way in the spacer? Low inspiratory flow. And even though a lot of the companies tell you that you don't need a very high inspiratory flow, I probably have 1 in 10 of my patients who cannot breathe in deeply enough for those breath-activated ones. So, or for the Turbihaler especially. And if they have cognitive impairment, then it doesn't matter what you do. You can try and explain. I've put together charts for people and done all sorts of stuff, but it's really very, very hard. And if they've got poor memory, you might be able to put your tablets in a Webster pack, but you just can't do that with your puffers. And for some of these people, maybe you might have to resort to a nebulizer and someone actually giving it. I don't particularly like nebulizers, but there is a place for them for some patients. So I don't think any of us have actually said, which puffer do you prefer? Which device do you prefer? I get called up to the hospital and I will be asked, can you please assess this patient to see which device suits them? And that's when I will actually usually get them across to a metered dose inhaler and a spacer most times. But if they prefer the other sort, we'll go down that track as well. And can they use it? So with a metered dose inhaler, I'm just going to go through all of these with you. The important thing, and I was taught by Asthma Foundation to always make sure the patient has their dust cap on, because the dust cap is there for a purpose. And having had it in my pocket for my husband one day and pulling it out, giving it to him and giving him a mouthful of dust, I can understand why. Good shake. breathe out gently. And this is where they tend to go wrong. It's like, no, breathe out gently. How did that look? Okay, I did it wrong. Wrong. How do I know I did it wrong? I can taste it. It was cold on the back of my tongue. 50% of the time I do a really good one. 50% of the time I can taste it and I can feel the cold. 100% of the time nobody else can tell. So just because it looks like they're doing it properly doesn't mean they're doing it properly. Please ask them, did you taste that? Was it cold on your tongue? And they think you'll want them to say it's cold. Oh yeah, I could feel it was cold. You didn't get it properly. Metered dose inhalers, even if you do it properly, you're getting about less than 10%, even if you do it properly. You have to breathe in at that second or split second. So you actually have to start breathing before you activate, because you've got to have that inhalation going as it activates. Otherwise, you're going to get that cold. And if you've got a metered dose inhaler in front of you, hold it like you would. There's the back of your throat, there's your mouth, and just feel how cold that actually is. So if that drops down in their mouth, they'll know, they'll feel that it's cold. Now, just for those people who might have children, they do ice burns with that because it's so cold, they'll give themselves ice burns. It is really quite extreme. So it is all about coordination. And I've been teaching this for 15 years, and as I said, 50% of the time I do it wrong. So spacers every time. I don't think anybody should be on a metered dose inhaler without a spacer. But there are those who say, but I have it in my pocket and that's how I want to do it. So at least explain to them how they should be doing it properly. And I actually show them the air, the gas coming out, and you can see it, and you can say, this is coming out and hitting the back of your throat. This is why we get so concerned about it. And let them feel it and let them play with it and see what's happening. So there's the common problems. Inability to coordinate inhalation and device actuation. Inhaling too quickly. And, you've seen the ones who go, because I've been told I've got to have 2 puffs. Well, if you're never going to get the first one, there's no way in hell you're going to get the second one. You've seen the smoking dragon ones where it comes out through their nose. I get those people to sit in front of a mirror and check how they're doing it as well. They don't shake it properly between, and they don't hold their breath. So the spacer, and that's the only way, as far as I'm concerned, for you to take a metered dose inhaler. We haven't got spacers for you, sorry. We're not that generous. So many spacers out there now. The old Volumatic is still probably one of the best, and it's still one of the cheapest ones. It is bulky, and that's why people don't like to use it. I could have sold this a few times over and made a bit of a fortune. I don't know if we can get the little ones anymore, Judy. Small ones, yeah.
You can get cardboard ones that are disposable.
Yes, yeah, they're good. Yeah, and they're very good, as long as we tell them don't keep them going for too long. I take them away when I'm on holidays because they're so good. And if you are in the bush or somewhere that you don't have anything, you can use your styrene cups, punch a hole in it and hold it that way. You can use a water bottle as long as there's no water in, because they're going to inhale water, or you can just hold your hand if they're having and just squirt it in. It's not going to be as effective, but at least you're getting some sort of holding device there. So good shake once again. You should explain it first, then demonstrate it, but because it'll take me too long to do them all, I'll just sort of talk as I go. Shake it, pop it in your mouth. I usually get mine to do it twice. It doesn't say that, but I usually get them to do two breaths just to make sure they have actually inhaled it. It talks about, here we say hold for 5 to 10 seconds. I have a large number of my patients who I actually teach tidal volume breathing with them because they can't do the breath hold. So tidal volume is what we teach children. Is that 5?
Yeah.
5. We usually say 5. Asthma Foundation say 4, I think, or somebody else says 6. If you say 5, you're pretty right. Children, no, 5. Patients can think of 5. And if it's 4, it doesn't matter. If it's 6, it doesn't matter, as long as they're getting there. But the tidal volume, if I'm doing it in the hospital, I'll write it in the chart. This patient has been taught tidal volume breathing, because I'm sick of people in ED telling them they're doing it wrong when I've spent, an hour explaining to them how to do it. Because when I do it, I'm assessing them. I want to know that they're doing it properly. Whereas the people in ED are very quick at saying you're doing it wrong. This is how you do it. Here you go, 6 puffs in there all at once, which you never multi-dose, despite one of the specialists giving a GP talk telling them that you can multi-dose. No, 1 puff at a time. And I was at a table of practice nurses, and we're all sitting there going, no, you can't do that. Don't do that. So some of the common problems are that people don't shake between, or they multi-dose, and maybe that they have a delay. They hold wait before they actually do it, or they have a whole conversation before they do it. And just remember, wash in warm washing up liquid, don't rinse, just air dry. I think there's a couple that are saying now you don't need to do that, but I would suggest that we just continue to tell patients to do it anyway, because you get confusion happening. If we start to have this space that says you don't need to, but this space it does, it's not going to hurt to do it. So let's go with what's not going to hurt rather than confusing them. I do love my spacer. I think it's very good, and it does make a huge difference. The other thing that I will show you this. This is really good. This is what we're saying about with people when they don't use a spacer. So you can see where most of the medication's going. It's going in the gut, because it hits the back of the throat and they swallow it. Whereas if you put the spacer in, the deposition's going to be in the lungs where it should be. And if you show that to patients, it's amazing how many of them go, well, why wasn't I told that before? So, and maybe they have been, but it's always good to reinforce those things. So the autohaler, I actually don't have an autohaler. I haven't used an autohaler in a long time, and I haven't seen anybody on an autohaler for a long time. Have you seen anybody with one of those? The most common people that we put on it was adolescents who didn't want to have a spacer. You've got to be kidding. I am not taking a spacer with me. And autohalers were really good because it was a breath-activated device and you could hear it click. The only thing is that when it clicks, often people would have like a glottic closure, because you'd do this, you'd hear it go click and you'd sort of gasp with it. But there are the instructions there for you if you ever come across them. I have only shown somebody how to use that maybe 3 times, and it was always adolescents. And the problem there is that they might not have lifted the lever up, once again tried to do multiple actuations, and the stopping inhalation after hearing that click. It's really easy to do. The AccuHaler, we've already sort of shown you a little bit about that, so I'll just go for it. Now, most people, I'm sure, have seen the AccuHaler. It's been very well marketed. Take it open, press it down to activate it, breathe out gently, and then I have trouble with the seal, and I always have. So has anybody ever tried it themselves? Does anybody else have that problem? Am I the only person in the world that can't seal properly? I am I? The only person?
No, you don't feel like you've got it.
Yeah, it's really hard. You're saying I find it hard. So there you go. Everybody's individual, and I would be. You found it. So I think, it's one of those things where we've got to be really aware that some people will find it works well and other people won't. That's why we're checking them. The other thing I've just mentioned, and I haven't got my tissues with me, is always tell them to wipe it afterwards. Every single one of these devices, I've seen bits of lip and lipstick and all sorts of things on there where they've just finished using it and put it away and then bring it out the next time and put it in their mouth again. And when I've mentioned it to them, they've gone, oh, I didn't realise. And I say, well, would you bring out your cup the next day and not have washed the cup? So it's a dry powder device, so we don't want moisture there, but you can just wipe it, and it's a little bit nicer for them to use. So all of your devices, Your spacer only needs to be washed out once a fortnight because you want to have that coating on the inside. But once again, get them to wipe the mouthpiece because that's the bit that's going to get a bit icky. So some of the problems there, not loading the device, failure to inhale deeply, and failure to hold the breath post-dose, breathing into the device. My problem when I'm teaching people is that I start gabbling straight away. So they say, oh, you're supposed to hold your breath. So that's a good reinforcement for me with patients that I've got to always make sure that I stipulate you do need to hold your breath because I know that I'm going to talk afterwards. The turbuhaler. So with the turbuhaler, whether it's the Pulmicort or the Symbicort or whatever, it should be flat. The only time there's a little bit of a difference is with the Symbicort, the first time you use it, it has to actually be turned twice before you then activate it, but only the first time you use it, and only the Symbicort, so not the Pulmicort or the Bricanol. So the Symbicort one does have a separate sheet, and I advise people to read that. I always say to them, take this home and just remember, because if they haven't, the first time they're using it, they're not actually getting the medication. So it's twist it one way, twist it back, breathe out gently, and then hold your breath. There are whistles. So if you don't think that your patient can do that properly, you can get a whistle from the company and you can check with the whistle. But once you've used the whistle, obviously they've got to have that. It's a one-person device. It's really important that they don't do it like that because it has little capsules on the inside and those capsules get moved around as you twist it. So if they activate it from the side, it actually breaks inside and the medication falls out. So that's why we tell them to have it flat, and then when you're ready to take it to your mouth to inhale it. And you'll have seen people doing that, and it's like when you see people using puffers in public and you know that they've done it wrong and you just want to jump over and say, you're doing it wrong, don't do that. It's how they get lazy too.
Do you have trouble, I've spoken to quite a few people lately, and they said when it gets down to about 20 doses that it's not as effective.
Yeah. I don't know if they lose confidence as well because they know it's at that point. It shouldn't have anything to do with it because they're individual capsules. So it really shouldn't make any difference. And I think if you can explain that to people that's actually, I've got a placebo that shows the capsules. And so I can say to them, look inside, and it's the AccuHaler that I've got there shows the little, I don't know what you call it, the different capsules in the foil there, and as it's pushed around it breaks it, and it's the same for these. So it really has no effect whether it's the first or the last. So it could be a psychological effect. I've seen my little red dot or my number saying that there's 20 less. I mustn't, it's not like a puffer where maybe you haven't shaked it up properly or that. It actually is individual. It would be like saying that my last tablet isn't as good as my first. They're all individual ones. So it really shouldn't have a problem with it. So it might be more of a anxiety part with them. And there's the problems with that device. Tell me if I go too fast when I flip through those. The Breezhaler. Have you all come across the Breezhaler? It's really nifty. I quite like the Breezhaler. Not supposed to have preferences, but I do quite like this. So with your Breezhalers, some people will have one that says Ombrez, Seabree or Ultibro. They're all the same types of devices. So it's a nice little device. You flip the lid and you have a little capsule that you put in there. And I think Judy put some capsules on the table. Yeah. So with the Breezhalers, the capsule is actually clear, whereas the Spiriva capsule is yellow, so you can't actually see. So they can actually see the medication in, I thought you were going to say something, in there. So you pop it in there, close it down. Now, give it a little tap, because sometimes it sticks. So if you just tap it down first, it'll be fine. You press it once. So you tell them always to just press it once. We don't want them to multi-jab it because it will break off little tiny bits of the capsule. So just the once to open it. They breathe out once again, and then they'll breathe it in. And it sounds, which is good, you can hear it. You can also taste it, and then they also have a visual. They can see that it's empty afterwards. So for the patients who need reassurance, it's a really good one in that respect. Now, one of the problems is, I think straight away, is getting the tablet out of the foil. And I have had a few patients that have said that they've had problems getting it out. Right. So did you hear Judy was just saying that if they're having problems with the foil, dog ear it and then pull it down. I know I had a few problems there as well. So yeah, just the one press. Now when they get that, there should be, the rep will give you some how to use, and they should have a how to use when they get them given from the pharmacy. Yeah. So breathe out gently. And then big breath in. Excellent. And no coughing, which was even better. Some of the patients will cough after it, and and it is actually quite normal as long as it settles within 2 to 5 minutes. So for some of the medications, it will actually activate a cough, so just prepare them. Okay, are you all comfortable with that one? And the difference between this and your handy-hailer is that the handy-hailer they've got to hold on to or they'll get charged. Oops, sorry. This one, they'll get one each time. So, they don't have to hold on to it. They will get it. Every time they get their script, they'll get a new one, whereas they don't with the Spiriva. And there is instructions in the packet as well. So some of the problems is not piercing the capsule or piercing too many times and shattering it. If they're not sure, we did have a time with a few of us that we were noticing that it wasn't piercing because when we went to breathe it in, it wasn't actually shaking. So that was when the rep said, just give it a little tap. And since she's told me that, it's worked every time. Make sure it's sitting in the chamber properly. Sometimes it's difficult getting the capsule out. We talked about that. And you don't need to hold the button in while you're inhaling. Now, I'd never heard of that before. And then yesterday, my asthma man, when he came in, he's also on Spiriva, and what he was doing with the handy-hailer was as he was actually taking the medication, he was going like that. So, you really don't know until you ask them, do you, what they're doing. So just, reinforce just the one press to break it. The capsule is dissolvable, so if it did happen to get into the lungs, it will eventually dissolve, but you still don't want it in there as an irritant, so just remind them about that. And like that one, swallowing the capsule, that's a bit of a problem too. The handy-hailer, I think I've gone through that a few times actually. Do you want me to show you again, or are you quite comfortable with the handy-hailer? Yeah. So do you want to have a play with one while you've got them on the table, or? And there are capsules there as well. I think most people have seen handy-hailers now a fair bit. Somebody did tell me that they might be changing the colour of the capsule as well, because obviously with the little breeze hailer, the fact that you can see that it's empty is a very good reinforcement for patients. So people do say they don't know if they've taken all their medicine with their handy hailer, so that might be a good move. Sorry? No, that one just sits in there nicely. So yeah, once again, you just press it, activate it that way, breathe out gently, and then into the mouth and inhale deeply and hold your breath. And it does, doesn't it? It does have that.
No, it's stuck in.
Oh, it's stuck.
It's stuck in, and I'm like, it popped out.
There was a time where the patients were telling me that a few of them were getting empty capsules. So if they're in doubt, tell them to shake it before they put it in. But I think that's been remedied. So there's some of the problems. Again, not piercing or piercing too many times and trouble taking it out. I'm going to quickly move on because the Genuair is probably one that you might not have seen. So you've got that on your table as well. So the Genuair is this little fella. So I hold the device horizontal with the green button up. Now, I don't have a green button. It's the real ones have the green button. Okay, so that's the green button. There is actually on the front, there is also a little red or green area. Red means that it's not going to work. Now it's working. Mine's green now. So when you're ready to go, you press and release the green button to load the dose. Then you'll get that little green sign to say it's ready. Breathe out fully. And you hear the click. It then turns red. So once it's red, you won't be able to get any more out of it. And you're supposed to hold your breath for 5 to 10 seconds.
This has already got something built into it, I take it. You just push the button down and makes it go. Yeah, you don't have to add it.
No, it's just literally, yeah, it's self-loading, exactly.
You just have to push it down.
You just have to press it down, and it goes all the way down, and it's green, ready to go. Breathe out gently. Breathe in.
Keep going. Could you just put that back in the freezer actually again?
Okay, I'm starting to spin out, guys, so I'm not going to do that one again. Having a few too many there. The other thing that to reinforce with people for all of these ones where you're breath activating or you're breathing in is that it shouldn't be jerky. It shouldn't be like that. You're going to send them into bronchospasm. It's a gentle breath out and then a nice deep breath in, but it shouldn't be to the point where they're jerking and they'll end up coughing with that. So some of the problems there is not loading the device horizontally, not checking that the window has turned green, and not breathing in deeply enough. Now, you're all feeling a bit spinny. You can imagine me by the end of the session. I'm usually really spinning out. So the patients often feel that way too. So just be aware of that when you are teaching them. Now, the ellipta is another new one. Have you seen this one before? And to be truthful, neither have I. I haven't seen this one used yet. So with the ellipta, it's made by GSK. So we've got that same principle of opening it up, ready to go. When it clicks, the dose is available. So as you open it, you'll actually feel that click. Once again, breathe out gently. And then nice big deep breath in and hold. Now there are air vents and they say to you make sure you don't cover them, so make sure you're telling the patient not to cover them. So I actually find that one a little bit easier than the AccuHaler, and I think it's because it's got more of a scalloping for your lips to be there. Okay, we all comfortable with that one? Yeah, and I think that with patients, a lot of the time they do lack confidence. Like, I don't know if you remember when the turbuhailers, they used to give you a blue cloth so you could show the patient when they breathed in the medicine coming in. I haven't seen a patient use this yet, so I haven't had any feedback from the patients whether they have any faith in it or not. And I think that that's something we don't talk about when we're talking about adherence, but if patients don't trust it, or they get the feeling that you don't trust it, then they won't get the response you're thinking. So there's just a couple of the problems, and I think everything we've said is the same. It's, not holding your breath, it's not getting the seal. A lot of the new drugs are on the market. Just remember, every time a patient starts on a medication, we need to check, we need to show them, we need to reinforce. In fact, the specialist I work with, he's a very young specialist, and he checks the patients every time, which is such a good practice that he does that. So we need to make sure that people are doing it, that the pharmacists are doing it as well, because that's the point of contact that we often forget. It's important to keep your knowledge up to date. As I've just said, I have seen this, but I've never really played with it. And the thing is that the first time you see it is usually with a patient, and you do look a bit silly if you go, I don't know what I'm doing. So try to keep up to date with it. Make sure that it is appropriate for the patient. It's in COPD patients, it's not whether it's age suitable, it's whether it's suitable for them and how they're able to use it. Provide education, verbal, visual and written. Written, I know that we're always going on about keeping it simple and all of that, but you can still keep it simple and have it written. And I know I take things home. I've got a bad back and the doctor wrote out 3 things: pain relief, anti-inflammatories, muscle relaxant, and I put it on my fridge. I'm a very good patient. I'll do what they tell me. But it reinforced it for me, and it meant to me that he was actually caring enough to write it down. So be aware that there's more to it than just what we think. What patients take away from that is a belief and trust in you. Demonstrate the correct technique. Repeat the instructions to them. Make them do it in front of you too. That's really important to do that. This is a lot of patient support that we've got, and there's lots of stuff. You go on the Lung Foundation website and you'll see all of that. Some of the stuff you can download, other things you can order online. I'll just quickly mention the COPE online patient education's coming up. That's for patients to do their education online. As I said, you guys probably know more than I do about your role. But for me, if I was sending a patient back to you, I would be thinking that you would know how to identify and screen for COPD, that you could do spirometry, which really is the only way that we can diagnose correctly. Assist in preparation of your plans. Educate patients about COPD and how to manage it. Now, I don't know how much time you have. I spend an hour with a respiratory assessment and touch on education. It takes a long time to reinforce this, so give them support literature as well. Send them to pulmonary rehab where they will get that education. Teach skills such as correct inhaler technique, guide behaviour change, assisting in goal setting and developing action plans, review and monitor patient progress. If they're starting on a new medication, they should be brought back and checked. If you were putting them on a new antihypertensive, you'd be bringing them back to check their blood pressure. Why don't we bring our COPDs back when we put them on a new medication? And refer to other services. Pulmonary rehab, I keep plugging it, don't I?
So I just want to confirm, in general practice, how do we refer to your services? Is it just via the Lung Foundation, like who will we physically send a
So,
to?
for people who are in my area, they can refer. We have a central intake line. So in Queensland, I think most of the health service districts have these intake lines now, and most of the major hospitals have got pulmonary rehab. So the private hospitals have them too, but Lung Foundation have a list of all of the rehabs in all the states. Well, most we hope we're pretty up to date, aren't we, Judy? So you can ring Lung Foundation and they will tell you which program, what they actually want from each person.
And so can they do the inhaler education and the review of the meds and stuff without the referral, or is that only post-referral?
It will depend on which service it is. So,
As in what area?
Yeah. So for my area, because I was fortunate enough to sort of develop it as I went, I will take self-referrals from patients and do education. But it's getting tight now with all of the changes because our KPI is to keep people out of hospital.
Yeah.
So our focus now is more seeing the ones who are in hospital, but I'm still taking referrals from doctors.
Is there a cost to a patient, or is it billed or has
Public health at this point, no.
Sorry.
At this time, no. It may change, you know. We're in a state of flux at the moment. And I have to plug this. Judy will shout at me if I don't. This is a active learning module for GPs, and it's on for Lung Foundation. So if you've got a GP who would be interested in this, Judy's got the handouts. In the Brisbane area. Now I know that look at that, we're actually just about exactly on time. Any quick questions?
I think this is not a question, I just want to say the practice that I work at, they've got a really good idea for getting patients off their smokes. They've got trophy boards.
Oh, really?
And if the patient's sort of given up for 12 months,
Yeah.
they can have their name put on, they request it. And there's probably about 50 names on the second trophy
Excellent.
board now. That's over about 10 years
Yeah.
plus, but still.
That's great.
And the patients look forward to it. We tell them that we're going to put a Band-Aid over their name if they, take up smoking again, but we never have.
Do you do you do CO monitoring with them? Or is it self, do they say
Oh, no,
that?
they have the date that they
Yeah.
have given up, and
Yeah.
we check that. Is that what you mean?
No, do you actually do a CO monitor to see if they're truly given up or? Yeah. Yeah. CO monitoring is a very good way to support what you're saying, because there are a number of people who will say, I've given up.
But it's not an obligatory thing.
No, so they probably have. Yeah.
So I think if they're being dishonest, they don't really.
Yeah. So it's good. But just for smoking cessation in general, you should, if you are doing smoking cessation programs, you should do some CO monitoring with them as well, because it's also a bit of an incentive for them to see the CO levels dropping as well. Yeah. So, was there any other questions? Just if you've got anything that crops up in the future, the 1-800 inquiry line number, what happens there is that if there's questions for me, the girls there will send me an email and I answer it after hours. So if you did have a question, and you can either leave your email address or I can call you, but it isn't after hours, I do it from home. So just if you do go away and think, I should have asked Ainsley something, please feel free to do that. Yeah, is that all? Did I cover it, Jude?
Oh, yes, send invitations for COPD resources.
Yes, the information online is great for that. Okay, thank you.
I'd like to thank Ainsley for what has been an excellent presentation.